Hello everyone, welcome to Physio Tribe. As you can see, we are masked up for our safety. This is Hussein. He's going to help us with our demonstration of assessment of cervical spine. In our previous video, we went over general overview of cervical spine assessment. Today, I'm going to demonstrate some of the simple ways of how to quickly do our evaluation. You always begin the evaluation with observation. So you want to look for any forward head posture, any guarding, or you see any adaptive shortening of muscles. So you want to check that out. That gives you an idea of which way the evaluation is going and what you need to test. After observation, we want to jump into palpation. So the palpation, we want to start from all the way from the cranium and come down cervical spine, thoracic spine, and shoulder complex as needed. Okay. So I'm going to have Hussein have a seat here, and we're going to go over the palpation. So you always start with the external occipital protuberance, and then you palpate to each side to see the nuchal lines. The trapezius originates from there. Then you come down and you start with C1, the transverse process of C1, then C2, and then you're gonna palpate the spinous processes of all cervical vertebrae. Then you're gonna go about a finger to 2 finger depending upon the person's size and the neck circumference, and see if the facets are tender. You're going to do it on both sides. Then you're going to come down and palpate for trapezius if there is any spasm. Then you're going to go forward and look for costoclavicular space in the first rib between clavicle and the trapezius, the bulk of trapezius muscle. Then you will palpate for thoracic spine and paraspinal muscles. Then you want to go and palpate for spine of scapula and shoulder joint if needed. Always remember, in cervical spine assessment, you want to treat the upper quadrant: cervical spine, thoracic spine, and shoulder joint. The muscles are interconnected and it's the whole mechanics together. So you cannot just treat one cervical segment without addressing shoulder joint and thoracic spine. Once you have palpated, you will have an idea where majority of tenderness is. If it's on one side, you know that that is where the pathology lies. This can be concurred from our history. The patient complains of pain on one side and radiating symptoms on that side. You know it's mostly that side which is affected. So as you go with your evaluation, you will start eliminating and trying to zone in on your diagnosis. After the palpation is done, we move on to the neurological screening, which will involve dermatome, myotome, and reflexes. So we'll start with dermatome. I'll have Hussein have a seat here. So for dermatome, we start with C1 and C2, which is the top of the head, C3, lateral neck, C4, top of the shoulder. Then we're going to keep the arms out. C5 is the lateral upper arm. C6 is the thumb or the web space. C7, middle finger. C8, little finger. T1, inner side of forearm. T2, inner side of the arm. Always check on both sides, and then if there is any abnormality, you can use different sensations, different kind of brushes to dive into the sensory examination. This will give you a little idea which nerve root is involved, if there is a nerve root involved. Then you want to strengthen that with myotome testing. For myotome, C1, C2 is neck flexion and extension. C3 is neck side bending. C4, shoulder elevation. C5 is shoulder abduction. C6, elbow flexion, wrist extension. C7, elbow extension, wrist flexion. C8, thumb abduction. And T1, finger abduction. Always check bilaterally, and that will give you some strength understanding as well. If there is less strength on one side, that will give you an idea if the nerve root is involved or not. After myotome testing, we'll move on to reflexes. There are mainly 4 reflexes you want to check in upper extremity. First is the biceps reflex. The root value is C5, C6. So you're going to hold the forearm here, completely relaxed. You're going to put your thumb on the bicep tendon, and then you're going to just give a stroke. The normal response is the little contraction of the bicep. Abnormal response is no contraction or hypercontraction. The next one is triceps reflex. So we're going to hold the arm here, completely relaxed, and we're going to give a stroke to the tricep tendon just before the insertion above the elbow. Same responses. Abnormal is either no contraction of the tricep or hypercontraction. The next one is the supinator reflex. We're going to hold the arm. We're going to find the styloid process, and we're going to strike right above the styloid process. The normal response is little supination or, elbow flexion. The abnormal response is thumb flexion or finger flexion together. That means that the central nervous system is involved. The last one is Hoffman's reflex. In Hoffman's reflex, we hold the forearm and we hold the middle finger at the middle phalanx, and we just flick the nail or the distal phalanx down. The abnormal response is the thumb or the finger flexion. That means that the central nervous system is involved. It points more towards myelopathy. Once you have done this, the next is checking the range of motion. So you will tell the patient to actively do cervical range of motion, and then you want to look for restriction on one side more than the other side, which direction is more painful, which movements are aggravating pain, and which movements are alleviating pain. That will give you an idea about what is the diagnosis, but also will guide you towards treatment. Once the range of motion testing is done, you do strength testing. Now, during your myotome testing, you already did strength testing, so you don't have to repeat it. You can do strength testing of any particular group of muscle or one muscle if need be. If you have found that one nerve root is involved and you want to do special testing for one particular group of muscle, you can do that. You can check the grip strength for objective measure. After the strength testing, you're going to do special test. The special test mainly is to check if there is any joint instability. So you want to check C1, C2 integrity. You can do the tilt test. You probably would have already removed it from your list of suspicion during your history taking and screening procedure. It is very important to rule out any fractures before you proceed with any evaluation. With special test, The other special test which is commonly done is upper limb nerve tension test. Now, at this point, if you already have the diagnosis down, you already know what's going on, there's no need to do the special test. When I was in school, I used to think, okay, now I gotta do this, I gotta do this, I have to do the special test. You don't have to do the special test. You can always do it on their first treatment day, but if the diagnosis is already done and it's obvious, you don't want to put the patient in more pain. So by this time, you already have the diagnosis and you're probably ready for the treatment. So in our next video part, we are going to maybe discuss a couple of cervical spine pathology examples and what findings we'll see in our evaluation in those pathologies, and then what to do for them. Thank you so much.